Good afternoon, everyone. And today is Friday, and we are back to our Forefront of Future Frontiers webinar, popular by the name FFF Webinar, a medical webinar series to translate novel scientific innovations and integrate them into practice. Organized by Scientific Society of Arupadavidu Medical College, Vinayaka Mission Research Foundation, deemed to be university. Myself, Dr. S. Deepa, President Scientific, will be hosting this session. Ours is a theme-based webinar started during this COVID pandemic. Until now, we have completed 13 series successfully. And now we are into an important and unaddressed theme in series 14, that is priority areas in public health. Today at series 14, episode 88, we have an eminent resource person from IIT Madras, Dr. V.R. Muaralidharan, Professor and Head, Humanities and Social Sciences, to explore the most controversial topic, which was in vast discussion during this COVID pandemic, that is healthcare economics. Now I'd like to invite our beloved Dean, Professor P.F. Kotu, sir, to give the opening remarks. Over to you, sir.
Yeah, thank you, Dr. Deepa. I mean, indeed honor to welcome Dr. V.R. Muaralidharan for this prestigious FFF webinar, which is heading towards the centenary celebration, 100th episode. And Professor Muaralidharan will be happy to know that this platform has been shared by teachers, scientists, researchers, educationists from all the 4 continents of the world, and notable personalities who have achieved something in their respective field have shared this, and that's how. And today our subscriber number base is exceeding 15,000, and uninterrupted 88th episode today. And today is one more edition, one more jewel for our crown, that is the social scientist or economic scientist is sharing his experience on a topic relevant to very much to us. Now, on this occasion, on behalf of our management, on behalf of our university, our Honorable Chancellor, I extend a very warm welcome to Professor Muaralidharan. And a couple of thoughts I find, I was just now discussing, just having a chat with him, the healthcare professionals' perspectives as regards this health economics. You know, I was telling you, might be, in my opinion, different from the economists or the social scientist perspectives, because our priorities in the healthcare management will be certainly different and focused, and their priorities might differ. This is some raw thought that came to my mind. And one more thing is, the moment we say economics, the healthcare persons means money, which is not so. When we say healthcare economics, economics is the science of scarcity, scarcity of human resource, scarcity of the distribution of resources, anything related to that is kind of a scarcity is economics. That we have to be aware. And we're talking about, I was telling that it is kind of a Greek and Latin for the healthcare professionals, because, see, one thing is our regulating council, National Medical Commission or a Medical Council of India, it found out that there was a lack of attitude, communication, etc. ATCOM module was introduced. For the lack of the knowledge in the healthcare economics, and we don't see any efforts for inclusion at any level, UG level, PG level, of some of the topics which make some sense to us, because all will not become teachers, some will become practitioners, some will become corporate sector bosses, they open up a hospital. So this kind of knowledge is very much essential. I'm sure this deficit will be timely recognized by the regulating council, and when so many things are being amalgamated in the medical curriculum, UGPG, there's some relevant issues to be addressed or topics to be included in the various curricula. And we always talk of evidence-based medicine. Now, economic decision making, something different. Evidence-based decision making is one for the welfare of the patient, and of course, economic decision making should also be towards the benefit of the patient only, but other issues will creep in. And one more thought that comes to our mind is India will be the most populous nation in the coming years. By 2030. Will be surpassing China, and more number of growing age people above 60 years of age. That population is also increasing because the lifespan has increased. So these are the circumstances wherein these issues of healthcare economics comes into. Best example I can give you is recently we have had a COVID pandemic. We saw it was a kind, in my opinion, if you see, when the first wave came and all across the country, oxygen shortage, drug shortage, this kind of a thing is a economic mismanagement. You were not realized, you were not prepared. So that was a time when this oxygen is not available, drugs are available, among the distribution is a problem, and at various levels, the day by day today one new protocol is coming. So we have experienced the first time experience of the importance of the healthcare economics. If we would have had a tinge of that, then apart from the disaster management, this is also kind of disaster only. The resource mobilization, resource distribution. If you are not going to be aware, then it will be a problem. And another issue peculiar to India is we always say that 75% of the population is located in the rural areas, and healthcare availability, accessibility to all the people across the country is not uniform. Even for a single person also, it might vary from place to place, time to time. When such is a discrepancy or deficiency or a peculiar paradoxical situations are there, then this healthcare economics is quite essential. You know, at one end, so much of money is being pumped out to bring up the indicators, maternal mortality, infant mortality, etc., which will not be possible unless we are aware of this health economics. So the need for health economics is quite justified. I already said increased lifespan, most populations, and the recent medical advances, those have been happening day to day. And more than anything, public awareness, what is available, what is accessible to a economist or a physician is available to the patient. So patients will contribute, question your decision. So these are some of the things which have necessitated the need for awareness about the health economics. These some thoughts they came to my mind. I hope they are quite appropriate. Our learned speaker will try to address some of these issues, and which will be of quite benefit to us. Once again, with these few words, I hand over the mic to Professor Deepa to conduct the further proceedings.
Thank you, sir, for the bright start. Actually, of course, sir had this experience during this, how we are struggling with this, managing this healthcare related economics, which we were really, which was really unaddressed to us. Hope this will be really useful for us, this one, to manage any crisis in the future. Thank you, sir. Now I would like to invite Professor Dr. Vishnu Bhatt, sir, Director Medical Research, AVMC, to introduce the resource person today. Sir, please.
Good afternoon to everybody. On behalf of management, dean, faculty members, and our guests and students, it is my duty to welcome Professor Muaralidharan and introduce him. Professor Muaralidharan is a faculty in the Department of Humanities and Social Science in IIT Chennai. He has obtained his master's in economics from this Pilani and later PhD in IIT Chennai. He has done several studies on health economics, healthcare, seeking behavior of population, healthcare in the public and private sectors, financing in healthcare, role of government in healthcare, health technology, assessment, environmental health, history of healthcare in South India, several areas he has done research and contributed immensely to the growth of knowledge in this area and also improve the healthcare in India. He has been the mission steering group of the National Health Mission, which is our flagship program by the Government of India. He has been member of Health Technology Group of Department of Health Research. He has been coordinator of the Operation Research Program of the Tamil Nadu Health Programs. So in various capacity he has worked. And he has several fellowships, so note a few of them. He is an international health fellow in Harvard School, Wellcome Trust Fellow, Rockefeller Founder Fellowship, Oxford University, and various other fellowships. And he has contributed immensely in the field. And I'm sure that his knowledge, expertise will help us and also will improve our research and activities in this field in the future. And today he has taken up the topic of healthcare economics and an overview of our country. And I'm sure that this will help us in improving our research and other activities. So welcome you once again, sir. And I back to Deepa for further programs.
Thank you, sir. I have, before I hand over the screen to the resource person, I have few announcements. The program is recorded for academic purpose and it is available in our YouTube channel, AVMC Puducherry. It is being live streamed also. So I request all the participants to mute yourself and kindly post your queries in the chat box. The queries will be taken at the end of the sir's session. Over to you, sir, Dr. Muaralidharan.
Thank you very much. Good afternoon to everybody here. I would like to thank the AVMC University, Dean Professor Mahalakshmi, Dean P.F. Kotur, Dr. Deepa and Dr. Vishnu Bhatt, and the entire establishment and the organization for having invited me to be part of this lecture series. Let me first thank Professor Kotu for more or less having summarized what I prepared to present today. So he captured most of the issues that, as you will notice when I go through my slides. Thanks for the introduction, and you have some clairvoyance. You captured what I was going to say. Okay. Let me first make a statement, and then we will go back to the statement perhaps at the end. I was articulating my view with Professor Kotu that a good practicing physician is also a good economist. So the way in which he described the domain of economics as, one which is dealing with scarce resources, and therefore when you have scarcity of resources, how well do you use the resources? The meaning of the word how well, of the expression, there's two sides. One is that you should spend it in such a way there is minimum wastage of the resources. That's one way of understanding efficiency, minimize the waste. The other is, even you may have minimized the waste, but still there is a challenge of how much to spend on what. You spend a rupee on something, that rupee is denied to something else. A rupee spent on you, the rupee denied to somebody else. So within health sector, should be spent in such a way that it should be fair. Everybody gets a fair share. That's the notion of equity. So we'll come back to this. So every physician, so when he's as a surgeon, he should decide whether a surgery is essential or not, whether the patient will benefit from it or not. And his time and resources should be spent on some evaluation, some principle that he should use. To whom should he allocate this scarce resource skill that he has? Someone who would benefit from it, or someone who would not benefit from it. So that's minimizing waste. Of course, you should sequence his patient in such a way that everyone will get to benefit from his skills. So that's a challenge. If he's thinking about it every day, he's a practicing economist. Likewise, someone at the very, very high level as a minister, okay, once he gets a pot of money from the finance minister, this year, this health sector in Tamil Nadu, I think, got about 17 or 18 crores, 18,000 crores. Minister's job is to allocate the resources, 18,000 crore, across the sector, across several competing programs. Very broadly, how much to spend on primary, secondary, tertiary? How much to spend on the new colleges that he has promised? How much to spend on various schemes he is introducing? Okay, a rupee spent on one scheme could have been spent on another scheme. So it's a rupee denied to somebody, another scheme. So he has to justify using some economic rationale besides other reasonings, but economic reasoning is one. Whether it is worth spending that 1 rupee extra on palliative care, geriatric care, or mental care vis-a-vis other programs that are already in place. Okay, so with this my brief illustration, what we are how I organized this presentation in this fashion. I hope there will be something for everybody at the end of this session to mull over. I'm going to go through a set of questions or issues that you may have read in the last 2 years or 5 years, maybe in the 15 years, 20 years of your association in this discipline. Questions that even someone who is familiar with reading newspaper will come across. I'm going to pose a few questions, then give some, shall I say, some evidence to think about those questions. Then let's discuss as we go along, what are your interests? What does typically economists do in the as health economists? We may not touch upon how they do what they do, getting into methodological issues of every issue as a researcher may take more time. And then we can spend some time on what is it that you can do as a professional from a medical college, or as a public health specialist, or as a nurse, or as a physiotherapist. Every one of us can play a role in promoting the public health delivery system or healthcare system. When I say strengthening healthcare system has two components, public, private. We have both presence of both in fairly large presence of both sectors. What is it that you and I can do, whatever be your professional background, to strengthen the public health system, given your interest? So this is a broad context, or rather outline of what I have in mind. Am I audible, sir, fairly?
Yes, sir.
You are audible, sir. Yes.
Yes. So one of the questions that we often hear when you browse through the newspaper very commonly, people are concerned about how much money is being spent by the government, by the people out of pocket, through their employers, through insurance companies. Somebody is paying for us, or most often we pay for ourselves, for both outpatient ambulatory care and as an inpatient, variety of things. If you see this table, I hope it is large enough, and don't try to read all the cells in this. I will just point out one or two things you see that alone. Rest of it you can go through it more leisurely. Look at the top row, which gives you total health expenditure as percentage of GDP. It is actually, as a percentage, it is falling. Should not be alarmed by this, because it's a percentage. The total GDP, what you call GDP, the size of the cake is also increasing. Okay? Of which, if you calculate the contribution, how much money is spent on healthcare from private, public, everything put together, some of you may know this amounts to about 5.4 lakh crore. Total amount that is being spent, all sources put together, it's 5.4 lakh crore. And if you look at it in terms of per capita, how much money is being spent by both private and public and other sources all put together, total health expenditure, that's the second row, gives you 4,297 rupees. That's in current prices. So it has increased over the last, from 2005 to 1200, from 1200, there's been a big jump. Next 10 years later, and slowly it is increasing in nominal terms. But if you look at it in terms of what is called real constant price at the base year of 2012-13, the increase has not been much. So from 2,000 rupees to 3,300, it has increased. More over the last few years, marginal increase, hardly any increase. Point is this: let it be even 30,000. Let it be 20,000. Right now we are about 4,297. That is aggregate, private and public. You look at the share of the government health expenditure as percentage of the total health expenditure, which is the fifth column, fifth row, about 40%. 40% of 4,200. It's not even 2,000 rupees, about some 1,600 bucks, something like that. That's the government spending per capita per year. Not much compared to many other comparable countries with the comparable income level. But we should not be worried about whether it is high or low. What we have to see is whether it is adequate. Certainly, per capita government health expenditure of about 1,600 bucks per year is not adequate, going by the other kind of statistics that we will see in the later slides. So we need to figure out how much is adequate. But before we say how much is adequate, we should know how much we are spending. So economists spend, this table that you see here is the estimates for 2017-18 on how much we spend, how much we meaning government, private, you and I, out of pocket, employers, through insurance, etc. To get this table, okay, it is produced by a team of people who should, we must thank the National Health System Resource Center, which is a think tank for the Government of India Department of Health and Family Welfare, located in Delhi. Last several years, there is a team which has developed the expertise to produce this for all India, for state-wise, and this report is available in their website. Please go and familiarize with this set of work being done, carried out by health policy specialists, particularly those who are specialists in financing. This is called National Health Accounts. National Health Account basically tells you where from money comes and what it is being spent and where is it spent, essentially. And that's not easy. You have to track the expenditure of every government, or if you're doing it for your own government, okay, multiple sources from which money comes into health sector, who gets to use it, and for what purpose, some of which goes for primary care, some of which go for tertiary care, secondary care. Functionally, you can break it down to number of subspecialty as well. If you have the capacity to track the money. So this is one set of studies, one set of research that goes on that economists undertake. To the extent it is robust, it will help the government in deciding, first of all, in estimating how much they are spending. Then they would ask the question, is that adequate? Then they have to follow up and say, it is not adequate, how much more to spend? And every question that we ask leads us to set of other questions for which we need empirical answer. To answer, for example, is that adequate? It is not sufficient to say, yeah, it is inadequate. Then what basis you say? So if you go to a primary health center, any nearby, you will see a range of a basket of services are provided, largely MCH, RCH, few other things, delivery related, 6 or 7 things we know. But under the Ayushman Bharat scheme, now the government is planning to provide a comprehensive primary health care, set of 12 services, including geriatric care, ENT, dental, mental, primary care. So you need set of people to be trained in that, to be able to identify a patient who needs primary care, and then be able to refer him or her. Okay. So if you provide primary care of those, for all the 12 services, how much would it cost? What kind of organizational structure we are visualizing at the subcenter level through district level? That would affect the amount of resources required. So you need to calculate the what if kind of costing. Provide under certain assumption that you have so much of people will, X number of people will seek care from facilities at various levels in order to be able to even estimate unit cost or provision of various services at primary care level. So this is a big area for those of us interested in being part of resource mobilization, and if you want to contribute to spending resources wisely, efficiently, and equitably. This kind of work is extremely essential. So let me then go to a few more examples about to illustrate what we do. Just giving you a detail of the same table in a slightly different manner. So the total health expenditure consists of both capital and what we call current expenditure. Capital expenditure refers to all kinds of investments on long-term, that has long-term use. If you took the extract that out, then the current health expenditure per capita comes to about 3,804, 805. Government share of this current health account is 33%. Out-of-pocket expenditure for the current health expenditure is about 55%. Okay, and we have, if you see the previous slides, you see the out-of-pocket expenditure of the total health expenditure over the years, it has come down from 69.4% in 2004-05 to 48%. What does it reflect? It reflects that more and more people are actually spending less and less out of pocket, perhaps due to more and more people are seeking care from public sector, which is also happening. So if you look at the data from the National Sample Survey reports, which are available on public, and we have reports on that, I can share that report with Dr. Deepa, who can circulate it to everyone here, both for all India and for Tamil Nadu and other states, we've calculated the footfall in public sector for primary and secondary tertiary care over the last 10 years have significantly increased, particularly for primary care. And you can perhaps argue with reasonably well that it could be the impact of the rolling out of National Health Mission as well. What you see here is, therefore, the share of the out-of-pocket expenditure continued to remain high. And it is extremely important for policymakers and for economists to highlight this and go into greater details to illustrate what is the consequence of it. Again, don't try to look at all the bar charts at one time, one go, and I will take you through slowly this slide. So we have asked a couple of questions. How much being spent? Is it adequate? How well it is being spent? Then we asked also, now we are asking, how well whatever is being spent or spent, and which means who benefits from this spending by government? I'm now speaking largely by wearing a hat of government or public policy. And you can draw from this questions relevant to your own context. You can ask this question to your own hospital. You have a big tertiary hospital. Who gets to benefit? Who benefits from this large hospital? Do you know the socioeconomic profile of your hospital? And you may have a mission, a vision to serve the poor. But you know how well, to what extent the poor are accessing? No, even though they may be poor accessing your hospital services, but how much financially they are strained, how much of hardship they face financially. Do we know that? And you may want to undertake a study in your own context and look at your mission and vision and see to what extent it is fulfilled. But to answer this question, we need a sound methodology. What we have done in the last 15, 20 years, using hundreds and thousands of unique data, as we call it, household level data, nationally collected sample survey, we have to analyze the socioeconomic background of every individual covered in these surveys and see whether they belong to poorest quintile of the socioeconomic group, or the richest quintile of the economic classes. Now, the richest here, according to survey, is not the richest as a billionaire. These are the richest quintile within those who are surveyed. And everyone who is surveyed will, from everyone who is surveyed in this national survey, we collect information on how much they spend on an average in a month on variety of things, food, non-food items, and medical items, other than marriage and big events. So we use that data to classify if out of 100 people surveyed, 20 are on the top echelon. They're spending more than, let's say, 20,000 per month, 30,000 per month. That is the highest quintile within the 100. So it is fairly representative. So what you see here is very interesting. From 1995, the blue bar, through 2004, 2014, and 2017-18, the last orange one, not the orange, the yellow one. Take the poorest quintile, this poorest quintile, Q1. Look at this. What this bar chart shows is that out of every 100 deliveries made in government system, out of every 100 deliveries made in government system, what proportion of mother come from poorest quintile? What is the share of that, those in poorest quintile? That is, bottom 20% of those 100 women who delivered, who come from the poorest income quintile. What is the share? So in 1995, it was 22%. It increased to 29%. In 2014, it went up to 42%. For some reason which we are unable to explain, it's come down to 22%. Okay. Nonetheless, if you see if you exclude for the present, just for the sake of presentation, if you exclude the 2017-18, progressively, it is becoming progressively pro-poor, the public facilities. Greater proportion of those from the lowest quintile are using public system. You would also find, and the last quintile, Q5, very interesting phenomenon. The share of the Q5 is falling, and it has increased to 13% the last round. We have to interpret this. Okay? These are percentages. Please remember, these are percentage. Doesn't mean in absolute number everything is falling or rising. It's a share. But nonetheless, if you just interpret only the share of the QI has gone up, share of Q1 and even Q2 have gone down a bit. Please remember the share. So, a greater proportion of those in higher income quintile also, Q4, Q5, have also begun to use public sector. You can use this to mean a couple of things, that they also see those in higher income quintile are also seeing the quality of care in public sector to be going up. This is a good thing. Without displacing, without crowding out, displacing, without denying the access to public facilities for those from the poorer quintile. If that is happening, it's good. So we look at both the numbers and then we say, and we have some interpretations on this. Yeah. Paper on that, I can share that as well with Dr. Deepa. Couple of more slides on the questions that you come across literally from newspaper. I'm picking up these. On the same delivery, then there is a lot of concern about increasing cost of care for delivery in many states, even in public sector, certainly in private sector. You see, this is for Tamil Nadu. How much is being spent for delivery, public and private? What is the effect of such a huge financial strain that you see on the right-hand side? You see the total for urban and rural aggregate, 2017-18. Average amount spent. This is an average amount spent in a private hospital for normal delivery is about 26,000. Caesarean is 42,000, which must be very on the lower end for large hospitals like any medium-sized hospital in urban areas. And compare it with the amount spent on an average in public sector, 3,400. Now, much of this 3,400 is spent on non-medical, not on medicine, not on surgery, not on doctor's fees. No? Expenditure for somebody, caretaker, transportation, food, and so on. On the left-hand side, in every slide, I'm showing a few questions. Questions that economists pursue. Questions that are of concern for policymakers. And each of these has a methodology. As I said, I would rather cover what we are concerned with, but not necessarily with how we go about answering these questions, which would take more time. Right now, I'm offering a course on global health and policy in which about 50 students are there. Most of them are from engineering background with no prerequisites. So it's a semester-long course in which we also tell them about methodology for addressing many questions. One more or maybe two more slides, then I stop for a few minutes before we proceed. There are other sets of questions that we are concerned with. Typically, if I were to ask as a student of AVMC, how efficient is our hospital? Difficult question to answer, but there are methodologies. No, every question is difficult. Sending a rocket to the moon is difficult. Extracting manganese noodle from the undersea water is difficult. Performing a surgery is difficult. But you have to also, somewhere, as someone managing the system, the hospital ecosystem, someone managing the entire public sector hospitals, should be asking whether the hospitals in certain districts are known to be functioning well, but how efficient are they compared to others? And why are two given public hospitals, district headquarters, performing at totally different levels of efficiency, even though they may all have comparable inputs? Let us assume that there are two hospitals, one in Karur, one in Tanjavur, or Nagapattinam. Two district hospitals, I'm just assuming, let's say they are comparable in terms of number of staff, physicians and specialists, overall, let's say, patient load. But there is something you may want to say that it's not efficient. Hospital X is not as efficient as Y. So how do we figure out, first of all, which is more efficiently run than others? Which hospital has less wastage than others? That's not easy to answer. But that is the question that we are interested in as social scientists, as economists, as policy analysts. What kind of information you need? Who will collect the information? How long? In fact, there is at the public sector level, there is this question that should you have a doctor for primary care in health wellness center, or should you have a doctor in primary health center, one or two or three? If you go to Kerala, they have health family centers in which there are 3 doctors, 24 hours, one every 8 hours. But if you find that number of people visiting primary health centers for seeking even primary care is low, then we ask the question, is it worthwhile having 3 doctors on 3 shifts when the output is low? Should you have just 1 doctor as we have in primary health center, but looking after 200 patients in the morning within 3 hours? Which is more efficient? Somewhere in between. So the question of quality comes in inevitably as we talk about efficiency. Efficiency is just not about minimizing money spent for 200 people, subject to certain level of quality. There are also questions on the issue of regulation that economists deal with. We speak very often. From the newspaper, we understand. Suddenly, there will be a bill that says this bill is called Private Clinical Establishment Act. It was introduced 1997 in Tamil Nadu, but now it's not implemented effectively. What are the reasons? What does the bill try to do? Who decides the answer to these questions? Regulate what? Are you trying to regulate? But there are regulations that exist at different levels in terms of training physicians. There is a regulatory body who can impart training. There are regulatory bodies for regulating drugs. Which drug can come into the market? There are regulatory bodies for establishing laboratories. Who is regulating hundreds and thousands of NGOs providing health care, primary care? They are in remote places. If you remove them, they would be, and the people whom they serve would suffer. Okay, so regulation has to be moderated, keeping in mind issue of access, affordability, acceptability. Everyone thinks about this question. We must regulate prices of services provided in private sector. How do you do that? Should you do that? Costs and benefits of regulating, the economics of regulations. So we economists also worry about conditions under which regulation, certain forms of regulation and incentives will work. How do we ensure, how do we align the incentives of the physicians to perform with the needs of their patients? Toughest question that we pursue. So just to give you a sample of questions that I have a couple of more questions, then I should probably stop. And we also work on estimating burden of diseases. Large number of economists are engaged in. I'm sure everyone here will know the concept of DALI and QALY and so on. Despite all the methodological challenges, okay, we are looking for some kind of metrics that will help us sense the pulse of the patient, as they say, pulse of the nation. How healthy the nation is. What are the various causes of disease, total overall illness? Can it be used for allocating resources in a rational manner? And then we have lots of other questions. As I say, there are debates. If you read the newspaper, you come across questions of people questioning the wisdom of government contracting out public health facilities. Is it effective, efficient? What does the evidence say? What kind of contracts we need to build? What will ensure that the private sector, which has got into a MOU with the, let's say, partnership with the government, will deliver what they promised will deliver? How do we observe? Are they observable? Okay. And what do we contract out? Can we contract out private inpatient or outpatient as well? How do we answer these questions? What can economists do to answer these questions? And there is a vast literature coming both from India as well as from other developing countries context. There is a new unit called Health Technology Assessment in India, established by Department of Health Research, Government of India 4 years ago, close to 5 years ago. Happened to be part of the technical advisory committee. I would request you to go to the website and you will see studies of this kind undertaken by a group of people, including economists, public health specialists, people like clinicians and others. Just given an illustration, 2 studies here. You see the PPT, you can read and go to the policy brief There are 8 studies we have completed so far by different groups of people across the country. Get a sample of the kind of efforts being made at the Government of India level to answer such questions. That will help directly public sector, because particularly if a diagnostic is being introduced by the government using public money, the question comes that is it worth it? Is it cost effective? Is it worth spending public money to support a particular diagnostic introduced, that has come into the market? Should be supported. Okay. How do we do it? So we have, as in other countries, it will take a long time, maybe another 10 years of journey to get the kind of credibility that NICE in US, UK has. Credibility that they have, equivalent to that, to be able to tell the minister that to not support this or withdraw this support, this diagnostic from being supported by public sector, public financing. So I've given you, I'm going to, this is the slide that shows as an answer to the first question, how, what kind of data we have on diseases. So again, ICMR has come out with the report that shows burden of disease due to communicable, non-communicable injuries, so on. This is a table that shows contribution of various causes of deaths over the years 1990 to 2016. And I'm going to end probably more or less here. I have a few slides to run through, but as part one, that you have even larger questions that economists are concerned with, social scientists. How and why some countries that are comparable in terms of in economic terms, but have health outcomes better than others with similar outcomes. I was part of this book. Again, it's freely available. You can Google and get this book downloaded, and which looks at performance of 5 different countries, which includes Tamil Nadu as a country. Okay. What makes, for example, Tamil Nadu's health outcomes better than states that are comparable in terms of per capita income? And we have 5 different countries. These 5 countries are not comparable. You take, for example, Bangladesh per capita income, and if you draw the income level of all the countries in the world, its per capita income of Bangladesh will be lower. But if you look at the health outcomes at the same level, you will find other countries which are lower than Bangladesh, which are at Bangladesh income level. Likewise in Tamil Nadu, Thailand. So why are those countries comparable at different levels of income, having different levels of health outcomes? So we looked at these regions, the comparative study. Over the last 35 years, some of the common milestones they have gone through, we feel that those are important. One of which is, for example, having a good drug delivery system, which Tamil Nadu has. Okay, many other states have also now. Okay, so I will end this part and pause and then ask the organizers as well as others how much time we have, and can we have some questions at this point so that I don't gobble up all the time myself. Dr. Deepa.
Thank you, sir. Sir, we have some more time actually, but meanwhile we have a few queries also, sir. Actually, you have started with the queries which we had in our mind only, like how much money is spent on the healthcare, especially in India, because always it is lamented that in India as a developing country, not much money is being spent on healthcare facility. 4 or 5 people, they sit together, the economist and the doctor and the healthcare provider and the journalists, they sit together and they talk, which I have seen most of the time.
Yeah.
And you have given a very detailed explanation, which we have not known till now. How much it is, how much is spent per capita, including per capita. Even though the data, which was very little bit difficult for us to understand, you made it, try to made it clear for us to understand. We have few more.
Please, let's listen to the question and then see if we can move, because the other sets, yeah, before we go on. Any other question, please?
Sir, one question is there in the chat box. Social security and health insurance take care of less than 16% of the health expenditure. Should we try to increase the percentage so that pocket expense can be brought down?
Yes,
That is the
of course.
question from Dr.
This
Vishnu.
16% that someone has pointed out, of course, this average in some states like Tamil Nadu, it will be much more because our CM scheme covers nearly about 5 crore plus. If you go to Uttar Pradesh, they have also this PMJ scheme, but right now the coverage is not as much as 16%, less, because they have recently rolled out. Whereas our CM scheme goes back to 2000, close to 2010. It has evolved over a long period of time. So certainly, Social Security scheme will help reduce the out-of-pocket expenses, definitely. And but private health insurance may not, because we found that even people who are insured, they are also spending out of pocket quite a bit. But you can say that they are richer people, they can afford to pay premium. That argument, I would say, is very specious. Just because you have ability to pay doesn't mean you can get impoverished after spending out of pocket. The point is, you should not have financial hardship. What does that hardship means is something that again economists work on. If you are spending 10% of your monthly household income, for somebody who is earning low income, it is a lot. Somebody who is earning millions of rupees, 10% is not. Somebody who is spending, is earning only 1,000 rupees a day, even 5% or 500 bucks a day, 5% of his income would be impoverishing effect. So we need a lot of work, but certainly your point that increasing, enlarging social security network will help, particularly for the unorganized sector. Right now, we don't have such a kind of program that we have for industrial workers, ESIS. We try to cover through CM scheme or PMJ, but still number of people are left out, like the migrant tribals. Reaching out, getting them enrolled is a challenge. Okay, so your point is valid. If the 16% should progressively go up, it's a well-made point. Any other question?
Yes, sir. Thank you, sir.
Sir,
May I ask one question?
I have a small question. Shall I ask
Yes,
Deepa?
yes, sir. Yes, sir.
See, Professor Muaralidharan, you have done a pioneering work in the uh, behavior, health-seeking behavior of the consumers of the healthcare, that is the patients. Am I right? So now, what I want is, what are your views on the behavior of our Indian population towards the health-seeking behavior of the people of the country? Because it varies how our cultural background, beliefs, because there is a mix of alternative system of medicine. So many things are there, various things. And the economical status from sky to the earth. So under such a thing, overall your views on the health-seeking behavior of our Indian patients, number one. And second thing is, can we think of, suppose we think of bringing in some change in their behavior? What are the salient things, what are the prominent things we can focus on to change the health-seeking behavior of our patients. Just to give an example, I say that the patient has got a malignancy, which is a end stage disease, and they don't seek it. The patients will still want to go to Ayurvedic or homeopathic people. They will tell us some mislead the patients, give false assurances. These are kind of things are quite common in our healthcare system. So your views on this, sir? How can we?
So thank you for this question. We have been dabbling on this for years, and I'm sure, as you know from the literature, hundreds of people are wrestling with this question as to how to change the health-seeking behavior. But what is the major issue here is that to take the poor, I mean, it's important to talk about the poor to illustrate this, and the rich also exhibit similar pattern for other reasons. If you take the poor, repeatedly you will find that they postpone seeking care till it becomes inevitable, till it becomes absolutely necessary. Because daily earners postpone seeking care, fearing that if they are absent half a day or a day, traveling from wherever is working to nearby a good physician, okay, he would lose his wages. That is a serious consideration. Then you will see he would also spend out of his pocket. Somebody will have to accompany him. So that person's daily wage also suffers. This is one of the biggest barriers. That's number one. I mean, that's one of the significant barriers. So we need to find a way, provide care closer to their employment. So I want to tell you that many of the camps, Varum Kapom camps, so are conducted where the MREGA work is going on. People who are employed under MREGA near the work site. Mobile vans are deployed to serve primary care near the place where MREGA workers are. Of course, they are working in hundreds of places. You may not have hundreds of mobile vans, but it's an idea. It's an idea, but then government will have to increase the number of mobile vans and cover more such workplaces where people are, many of them are 40, 50 years old, women, they need care. Provide them near the work site. I'm just suggesting an idea which is not mine, which is practiced by some governments, even including our governments. So this Makkalai Thedi Marthuvam, I have already been to a few places, but the idea is people who are already in the line list of NCD care, NCD patients. So I know this lady is already in the line list. It's for those people who are in the line list whose names are there with the VHN, Village Health Nurse. Okay? As part of her home visits, she carries this medicine as well, once in a month. 8th of April, 9th of April, she knows from her list that who are all there in my outreach program today. Go with that and give it to them instead of them coming here to the center. Whether it is costly or not, but the point is access is established. People who don't comply are also part of the reason is why they don't comply is that they have not come and collected the money. Sorry, collected the drugs. So this is major reason for not seeking care is daily wages, financial reasons. And the other reason is the following. If you look at the NSS data, self-reported morbidity is highest in Kerala. Of every 1,000 people or 100 people asked, did you have any illness in the last 15 days? 400 people say yes. I say every small sneezing is a sign of some ill health, perhaps. If you see the Bihar data, out of 100 people, not more than 20%, 50% report that they were ill the last 15 days. So this is self-reported one. If you probe, if you do some blood test or whatever, if you probe, you will find that there also actually people are having signs of illness. But they're not reporting. They are going about in their daily work, I should say bravely. Okay. So not reporting is due to, can you say, not being aware that they are not in good health. Nonetheless, the fact remains that health-seeking behavior, unless the economic barriers, unless the access is improved, unless you create more awareness, okay, of latent conditions. So that is one set of. The other set is that because I don't have access to an health wellness center or private clinics nearby, people would go to other schools, other providers. Presence of quacks is still very high in the Indian context, both in private and in urban and rural areas. It has reduced a bit in many parts, but it is still significant. You know, studies after studies of TB patients have shown that where they go first, 3 or 4 providers before they eventually come into formal system. In TB, particularly, we have a national program the last 40, 50 years. Despite having a national program for 40, 50 years, the share of public system to cater only about 50% of the TB patients seek care from public system. Remaining 50 from, we say, private, of which the share of the non-formal is very high. Okay, there comes other reasons, stigma and few other reasons. So that's this awareness and health-seeking behavior is there as a challenge. HIV was an example. In general, when we say 70% of the total outpatient care is catered to by private sector, we don't mean hospitals like you or Apollo and other established people, but a large part of the 70% refers to non-formal, primarily due to access. Geographic access is still a huge problem. That's my very inadequate answer because it's a complex question. Thank you very much.
Thank you very much, sir.
Thank you, sir. As you said, the health seeking, they want to go for work in the daytime and they want to consult in the evening. Most of the government sectors, they don't have the evening OPD.
We have now
in the Tamil Nadu they have started.
We have now evening time till 4 o'clock. HSCs are supposed to be there till providing clinical care till 5 o'clock, but that's only not all the 9,000 HSCs that we have function in that way. But eventually we need to go below HSCs as well, providing care through ASHAs or other such extension workers closer to living places.
Yes, sir. This Makkalai Thedi Marutvam, as you mentioned, it has. I hope it will have a huge, very nice response from the public. And basically, myself being obstetrician, I see more money spent on maternal health care, and women's health, especially in Tamil Nadu. So I have a question, sir. Whether the it is the healthcare system which is operational, which utilizes the economics better. Whether it is the healthcare system, because the same money is been, whether it is the same money which has been allocated for different states, some states they are able to accomplish the healthcare better compared to the other states. Whether it is the healthcare system per se which is operational, because in Tamil Nadu I see there is CMOG and so many things to take care of this obstetrics. Compared to, and we see the maternal mortality is also comparatively less compared to other many other states.
How
Is it?
robust the public health system as well as private health system also has been. Since we are talking about government policies to strengthen not only their own system but also private healthcare system. But we have not been, we meaning the government has not been able to forge a healthy relationship with the private sector so far. But except for primary, the tertiary care health insurance scheme to a certain extent. But how do we engage with the private sector, especially for primary care, is a big challenge. Nonetheless, public system as such is far robust than many other states. That's no doubt.
Thank you, sir. One more query we have. Whether the expenditure, I have got it in the chat box, whether the expenditure on the human resources for health is also included in the healthcare economics as per the budget allocation.
Yes. In fact, the expenses that I showed you per capita includes everything. I would request this gentleman to look at the report that is available in the website of National Health System Resource Center for the latest year 2017-18. It's called National Health Accounts. Gives you the methodology of how they calculated. It includes drugs, includes all HR, includes other various expenses made, capital and other expenses, right from the center to state to local bodies. It also collects information on private sector through surveys and other sources available, but it certainly includes human resources. As you know, in unlike other sectors, the quality of the system improves with appropriate human resources. Okay, you may have robotics there, but you still need a physician there. So human component in healthcare is close to 50-60%, and the figures that I've shown include all that. Challenges. Let me pose a question to you, the person, and which is also a question that we are all facing. Do we need to cater to the basic primary care, whatever your conception of primary care, let's say at sub-center level or even at PHC level? How much of the primary care can be met with a doctor? Should a doctor is a trained doctor is necessary, or can you do with a trained person in primary care for 3 years, like a good nurse and a team along with her? This is a big question. And there are studies from different parts of the world shows that quality of care, largely speaking, don't suffer. But what is your take on it? How do you answer this question? My take is this: you should not say something as my impression is, but how do you empirically show that it is cost effective to provide primary care for a large number of patients with good trained nurses than a physician, which is more costly? How would you answer? Yeah. Doctor, whoever asked, how do you answer this question?
I have not asked this question, but my thinking, can I tell?
Yes, sir. Yes, sir.
See, basically, I think the problem arises because they do not know the limitations. So you have to have some limitation for the basic health workers who may not be trained. So if they start handling cases which they should not handle, or and they are not able to identify the cases which has to be referred, then the problem comes. I think that is the issue which probably creating. If say what can be treated by them, when they should refer,
Yeah.
how they should identify, this training has to be imparted.
So you trained CIS in such a
But
way, just as an
we are
undergraduate is
training them. We
trained
are just
not
telling
to
them, you
do,
do, then it's a problem.
yeah, just as an undergraduate is trained not to do cardiac surgery, these guys will be trained in primary care and they would know when to refer. Okay, that becomes part of the culture, and in Sri Lanka and many other countries, it's part of the system. But in our system, of course, it has not been accepted yet. But there's a strong case in Chhattisgarh. There was a court case between Chhattisgarh and MCI because 15 years ago they started the 3-year program called Rural Practitioners Medical 3-year program, and MCI said it's objectionable. But the chief minister said that we can't wait for all the trained people to eventually settle and serve in rural areas, and that will take years together. In the meanwhile, I will have mothers die of simple causes. Cannot afford to do that, and therefore he went ahead, appointed them, and they were serving in districts where they come from. They were appointed. Of course, you have to see that they don't overstep, call it overstep. Okay, but you have strong economic reason, equity reasons to go ahead to have these people deployed. But the old theory of you produce more, and then eventually they'll percolate and go into remote areas has not been borne by evidence. More and more people in places where more people are practicing. So that's the strong policy argument.
As STB, as discussed, I'm here confirmation. I'm here with submitting a list of associate professors by
I can't hear, sir. Madam, what is the question? Dr. Deepa, what is the question?
Please go ahead, sir. There was some disturbance.
Okay. So I don't know if we should stop here. It's 4:20, but basically I'm going to refer you to a book and request your library to buy this book, Encyclopedia of Health Economics by A.J. Collier, and urge everybody to read the first 2 or 3 chapters. Basically, the chapter talks about what economists do. Each of these boxes are explained, and then you have a vast number of articles that would be of interest to people depending upon their background, what they wish to do. Okay, so but this book electronically will be available, and you can have it in your library. So I have only tried to summarize the first chapter what from that book, so I don't want to much of it I have said in the presentation I made with the slides. So I would urge as a I won't say as a homework, but as to continue a journey with this book, with the recommendation that to request your library to acquire this book and have it accessible to your students and others, and have periodic, maybe through your journal club, take a chapter, discuss, and do some group work. Take a problem and do some group work. I also would like to urge as a reading the guidelines for economic evaluation of healthcare technology, which is available in Health Technology Assessment in India website. So these are the two suggestions I make to continue to enable those of you interested in their journey in healthcare policy and economics. Perhaps I will close with that comment.
Thank you so much, sir. Dr. Muaralidharan. Sir, it was such an informative session for all the healthcare professionals we have joined over here, because it was totally a different topic, but we have today I felt that I haven't known about this topic since long, but as a healthcare profile, provider who will be designing even the healthcare systems, we are supposed to know about this. Then only we'll be able to provide it better. That's what I felt. Thank you, sir, so much for this session. We have noted down the book which you have mentioned. All our undergraduate students, postgraduate students who are going to become a healthcare provider or going to be a part of the healthcare system, either it is a private or a public, they are supposed to know about the health economics. That's what I have learned today. Thank you so much, sir, for the very nice session. We'll be having this in the library as you have mentioned. Dr. Vishnubat sir and Dean sir, you have some more to say, anything more, sir?
I think most of the points are clarified, and I think he has taken us through the health economics and problems we are facing. So I think there is a long way to go from, as he has suggested. This rural-urban disparity, of course, is there. I think main issue probably the transport system, and suppose patient gets a problem, there should be a good transport system. And education is another aspect where health-seeking device comes along, probably along with the education also, although they may not be directly related. The moment you improve the education level, probably they are thinking as well as looking at this health also will improve. And as you concentrate more on communicable diseases, non-communicable diseases will increase. So I think we should also work on that non-communicable disease lifestyle modification, which is likely to diabetes, hypertension, they are all on increase. So I think that should be there for it. Thank you very much, sir, for a very nice
Thank you
talk.
very much. And I thank all the organizers as well as the participant. I hope everyone has at least one question issue to think about. Thank you very much.
Thank you, sir. Thank you all the participants. We'll be meeting on next session next Friday afternoon with another episode of our FFF webinar. Thank you, everyone. Thank you, sir.
Thank you.
Sir. Thank you, Dr. Vishnubat.
Thank you. Thank you.